participants and good night participants. So thank you for joining in. So we are very happy to inaugurate this TB Guardianship program, which is advancement in diagnosing drug-resistant TB. So we have a lot of eminent speakers who have come in. So we will be starting off with the inaugural session for around half an hour's time, and then we will be having the remaining program which is there. So we would start off with Dr. Nishant. So sir is from the ICS, that is Indian Chess Society. So we will have sir. Sir, you are online, sir.
Can you confirm that? Can I start?
Ma'am, is sir audible?
Yes, we can hear,
yes,
sir.
ma'am. Yes, sir.
Okay, thank you so much, and greetings of the day. Good evening. It's really very heartening to witness clinicians and microbiologists on one platform, and I saw the panel, Dr. Kamila, Dr. Chopra, Dr. Irwane. Amazing panel there. Unfortunately, I am not in the country, but it's really heartening to see both the clinicians and microbiologists. And myself being the focal person for the lab network, I would like to emphasize on the importance of the primary pillar of strategic plan, which is detect, detect, treat, prevent. So detect, and the role of diagnosis cannot be overemphasized. We've seen a lot of progress, and while molecular tests offer, rapid detection, the growth-based techniques are essentially needed for, DST as well as for treatment monitoring. We all know what their place is, so important in getting the right treatment started at the shortest possible time. In addition to that, culture sometimes may be, needed in certain extra pulmonary TB. Automated liquid culture becomes sometimes the method of choice in these instances. And also, liquid culture and DST using BD's midget system, you all are aware, is the gold standard for phenotypic DST. And you all are, most of you, who are in the panel are, been so supportive, and you've been, as a very important stakeholder in the whole expansion of the lab, and the way NTP has appropriately positioned the liquid culture DST in diagnostic algorithm. We all have come a long way from, one or two labs. One was in NTI, one was in NIRT, and now we have 90 plus, lab which provide DST services to the TB patients in India. BD has, been engaged earlier also with the program, and supported the DRTB initiative as CSR. I remember the Rewari, initiative, and in the current endeavor, this is the TB Guardianship program of BD, which USAID is supported. Have come together in organizing webinar educational series. The first one is today. So I really congratulate the whole team, all the organizers who were part of this whole endeavor. And we've seen in prevalence survey that there's a lot of issue with awareness among the general public. Plus, there is some amount of, I would say, this group I can talk that we have to make the, providers also aware of the latest modalities which are there, and the latest, diagnostic, algorithm which is there in the program. So I'm so happy that the series has started today. We are on the, eve of World TB Day. And this, I say, is indeed a welcome step. And I wish the very best to all the speakers and the participants. I wanted to be there physically, but I'm on some assignment. I'm not in the country. But all the wishes to all the organizers. And at the end, I would like to say, TB harega, Desh jeetega. Jai Hind. Thank you.
Thank you, sir. Thank you. Very well said, sir. Yes. Jai Hind. So I think we should, defeat TB as, when the Prime Minister has told, we should, we have a TB Mukta Bharat. I think all of us play a very important role in that. So next we have Dr. Namita. So she's the Head of Medical Affairs and Global Public Health Medical Affairs. So ma'am, we'd like to have a few words from your end.
Yes, thank you, Arun. I think Dr. Nishant has set the context so beautifully. So he has made my job much simpler. I would, my warmest greetings to all the participants and panelists over here. We have such an excellent panel. It is such a delight and honor to be here. And thank you everyone for joining us on Friday evening. I know it's not easy. And, while NTP has been doing a marvelous job of eliminating TB, we all stand together united in a mission to support that goal of elimination, right? And that passion brings us all here. Like Dr. Nishant rightly said, the role of diagnostics in eliminating TB is critical. It's very central, and like he said that while we have molecular diagnostics, which are an excellent tool, culture has been the gold standard since times immemorial, and now with liquid culture being there for the last many decades, which is faster, which is automated, I think they both form an excellent complement to helping us diagnose pulmonary and the ever-increasing extrapulmonary TB as well, and to pick up slow-growing mycobacteria and so many other things, diagnosis of drug-resistant cases, diagnosis of drug-sensitive cases, drug susceptibility testing, and all of that. I think the panel here and the audience here is very well aware of that. BD, like Dr. Nishant said, has been committed to the space of TB. We've been working with the program on educational initiatives, on capacity building initiatives, on CSR projects of bringing diagnostics closer to the patient. And as an extension of that, we are here. We are feeling very honored to be here with all of you to bring together TB Guardianship program along. And I want to really thank our partners, our partnership with Union, USAID, Indian Chest Society, and of course NTEP, who have really made this possible and made this happen. So a big thanks to everyone. And with that, I would like to, reiterate our commitment to eliminating TB. And BD will continue to bring the best solutions forward for diagnosis of TB, whether it's in the molecular space or in culture. And so we will continue to be there for education or taking such initiatives of education capacity building forward that we are committed to. So with that, I welcome everyone again, and I pass the floor to Dr. Rakesh. Dr. Rakesh, please, you go next, and please share your thoughts. And thank you, Nitin, Arun, and the IDS team for organizing this. Thank you so much.
Thank you, ma'am. Yeah. I think over to you, sir.
Yeah, thanks, Dr. Arun, Dr. Namita. And all the dignitaries present here, including Dr. Camila, Dr. Radha, and Dr. Nishant. So greetings from the International Union Against TB and Lung Diseases. As rightly mentioned, it's very heartening to see 150 clinicians and experts across the globe joining in this meeting on a Friday evening. We all know, that shows the importance of this particular meeting. We know the political declarations at the United Nations high-level meeting, the first held on 2018 and later held on 2023, where all the countries agreed to achieve few targets. And one of these targets is that at least 90% of the estimated number of people who develop TB are reached with quality-assured diagnosis and treatment shortly. And we know in last year, there were 7.5 million diagnosed with TB, even though there is a lot of missing TB people, with an estimated more than 400,000 people with RIF-resistant TB or drug-resistant tuberculosis. Deaths, if you look at simply the number of deaths that is happening, even in India, it is estimated that every 1 hour, nearly 40 people die because of tuberculosis, that too because of a preventable condition. So that's why it's being considered as a not only as a health issue, but as a developmental issue for the country. That's why the Prime Minister has included that in the ending TB targets in the Sustainable Development Goals, and is trying to achieve those targets much ahead of the global targets. The WHO's NTB strategy clearly calls for early diagnosis of TB and universal drug susceptibility testing. And we know that the WHO has just published their 3rd edition of the consolidated recommendations for TB diagnosis 2 days back. And we know the diagnostic options are now, especially for people for detecting the drug resistance, are increasing. And thanks to all the good manufacturer engagement and the research that is happening in this field, ensuring that everyone in need can obtain an accurate diagnosis with the latest state-of-art technologies will advance efforts at preventing and finally ending tuberculosis. Last week, I was discussing. I visited multiple big private hospitals across the country for initiating steps, the system for TB elimination in the private sector, where I heard lots of stories, including medical legal issues now coming up, especially with related to diagnosis of TB. Especially extrapulmonary tuberculosis, where the clinician makes a diagnosis, but ultimately, eventually, that will be challenged in court or consumer court for various reasons. So that actually talks about, that actually emphasize the importance for getting a microbiological confirmation, knowing the susceptibility pattern at the earliest while we initiate the treatment, and knowing what are the current standards existing in the country and the globe. We know BD Global Health. I mean, it's not to everybody. They deploy a strategic combination of resources and technologies aimed at making a very positive and sustainable impact in the globe. And BD products are a vital part of the global healthcare system. Our partnership with BD as part of the union is through a corporate TB pledge initiative, where through the project Sankalp, they are actually helping in finding the cases in the Rewari district in Haryana through a community-based. We are very happy to collaborate with this initiative, which is a 3-part webinar series. And I'm sure that this initiative will focus on enhancing TB diagnostic practices. We have a good number of resource persons, the best available resource persons in this domain. And I really wish all the best for this wonderful initiative. Thank you so much.
Thank you, sir. I think it was very well said, and you highlighted the importance of TB diagnostics also. I think next we will go ahead with Dr. Noel, sir. Sir, if we can go ahead with your... So Dr. Noel, sir, is a microbiologist who's working at JIPMER Pondicherry. With the interest of time, we will not go for a complete introduction. So Noel, sir.
Yeah. Yeah. Can everyone hear me?
Yes, sir, you're audible,
Hello.
sir.
Yeah.
You're audible, sir.
Good evening. Good evening, one and all. Are the participants also joined, or is it just...
Yes, the participants also have joined in, sir. We have more than around 150 participants, sir.
Yeah, okay. Fine. They already NF has been told about the importance of TB and the role of culture and other diagnostic methods in this. So my session, I basically like to emphasize on the few important facts. Some of any new PGs may not be aware of.
I'm sorry, sir. Can you just click on the slides, sir, so that the slides get activated?
You want me to display the slides? Yeah. Okay,
yes, sir.
fine.
Yes, sir. You can just, as we have discussed, you can just open it.
Yeah, I have put it. Is it
just click on.
Slide, is it same?
Not yet, sir. It's active here, but
okay.
I think if you can just click on the slide from your end, sir.
Oh, I don't know where it went.
So video bridge slides.
No,
yes, a video bridge slides.
I went into the manage.
Yes,
Hello?
below that. Yeah, yes, below that, Dr. Noel slides is there, sir. Dr. Noel, Dr. _Noel _TB. You can just scroll down a little bit, sir. Just you can minimize the presenter discussion.
I have gone into the questions page. How do I come back?
No, you're going to question page. You will cancel it, sir, at the top. Escape it. There's a cross button at the top, sir. If you're canceling it.
Button. I don't know if it will close the entire thing.
Okay.
Yeah.
In the meantime, Radhanam, can you just
Yeah, I have. Is the slide visible now?
1 minute, sir. It's not yet showing for me. Yes, it's now showing. Yes, sir. Yes, sir. You go ahead, sir.
Yeah,
yes, sir.
Okay. Yeah. Sorry for the inconvenience and. So I
Yes.
would like to just set the platform started by some brief introduction about some definitions in the interest of some PGs who will be there. Some of the recent definitions which are there, like presumptive TB. Earlier we used to refer to the term TB suspects, but now all the clinically suspected cases who are having signs and symptoms of TB are to be referred as presumptive TB. And then once we confirm them microbiologically, as of now, these are the few methods which are acceptable by NTEP, which includes smear microscopy, culture, or one of the WHO endorsed rapid methods that is a NAT technology, either CBNAT or TrueNAT. So once they are confirmed by that, the patients can be labeled as bacteriologically confirmed. All the other groups who are having only clinically confirmed diagnosis, even including histopathological diagnosis, will be labeled as clinically diagnosed TB. Next, I would like to emphasize that importance of universal drug susceptibility testing. So, with the move to eradicate TB or eliminate TB, the main move is one of the main moves that have a universal drug susceptibility testing. I think the student might be thinking, knowing that the earlier system where all the patients used to be routinely started on the CAT1 or CAT2 like that. Now we don't have the CAT2, and that way without any drug susceptibility testing. But now, as per the NTEP guidelines, it is mandatory for all the notified or diagnosed TB patients to be tested for at least some basic drugs. One of that is the rifampicin, and subsequently, if rifampicin is resistant, then we need to test for the fluoroquinolones at least. But that is at least a minimum requirement, but doesn't mean that we have to stop with these drugs. Universal drug susceptibility testing means that we need to try and look for at least the rifampicin and the other first-line drugs, and if needed, the second-line drugs for all the diagnosed TB patients. So, in this background, we need to think that all notified or diagnosed TB patients as presumptive drug-resistant TB. So, it's not that only when the patient doesn't respond or there is a treatment failure, then you think of drug resistance. The program says that upfront, when you are diagnosing a patient, please presume this is something like universal precautions or standard precautions which we have as microbiologists must be knowing that. So that way, all TB patients should be should be considered initially as presumptive drug-resistant TB, so that they have to be screened for drug susceptibility. And of course, during the course of treatment, if there is lack of response and other things, when you can still, even though if you have initially labeled them based on the rifampicin susceptibility or the first line, if you have labeled them as drug sensitive, and subsequently during the course of treatment also they can develop resistance, and at that time also again you can reclassify them as presumptive drug resistant TB. Okay, and quickly telling about these two terminologies like drug susceptibility testing and drug resistant testing. Outwardly, both of them might look the same, like opposite sides of a two coin. But these terms in the program, in the context of the program, are used for specific purpose. Like, for instance, drug susceptibility testing always refers to testing by one of the phenotypic methods. So please, you should use accordingly. Whenever in the context of TB, somebody uses the term drug susceptibility testing, it refers only to the phenotypic methods. Phenotypic methods means culture-based methods. And drug-resistant testing, on the other hand, refers to in vitro testing using one of the genotypic methods, but it's a molecular methods. So it's important for us to know the distinction between these two terms and use it appropriately, so that the other person who is listening to you will be clear when you use these terms what you mean by that, which technology has been used. Anyhow, I know there are speakers who are going to talk on the details of all the diagnostic methods, but I just wanted to give a background on these methods, and maybe they will be adding on to it. So these are the few methods these are the methods which are endorsed by the NTEP as of now for diagnosis of TB, which includes microscopy. Earlier we used to do the Zeal-Nielsen staining, the acid-fast staining, the conventional method. But now we have moved more into the fluorescent staining method using the Orman phenol staining because of the advantages. And then we have but these two, with the introduction of the fluorescent staining, actually it really helps screening a large number of samples because of the different contrast that we have. And unlike the earlier fluorescent microscope, the LED fluorescent microscope also comes at a lower cost and cost of maintenance as well. So that is the thing in the terms of microscopy. And then we have culture. Everybody knows that we have been for a long time using Lowenstein Jensen medium, the solid culture medium for diagnosis culture. But then again, we have moved away from it and moved more in towards liquid culture, especially the midget 960 culture. Because mainly it's a robust equipment which can incubate, as the name indicates, up to 960 tubes at any given time point. And not only that, unlike the LJ medium, which is routinely read once in a week, the liquid system, that is the midget 960 system, reads all the tubes which are incubated every 1 hour. So that really cuts down the time to turnaround time. In addition, it's also a very enriched medium. So that importance of culture has been already emphasized again and again. Though it has a limitation of a little delayed results, but it can never be replaced by any of the newer methods or molecular methods. We always have a specific role for culture. I'm sure the speakers who are going to talk will emphasize the importance of culture in the context of TB. And subsequently, maybe we can further discuss about it in the panel discussion as well. Next part is drug susceptibility. The same way, drug susceptibility testing now primarily is being done using the liquid culture. We no longer use a Lowenstein Jensen medium based method because it takes time. And to say that the liquid culture system, the midget system, has the drug ability of testing all the drugs, first line, second line, including the latest drugs like bedaquiline as well. So that has its own role in diagnosis of drug susceptibility of the isolates. And moving on to the molecular test, the two methods which are primarily used for diagnosis is the NAT technology, that is CBNAT and TrueNAT, and upcoming is the BD Max is also coming up, and that also has the same advantage of a rapid molecular based testing. And we in the program, in addition to this, for routine first line and second line drug resistant testing, we use LPA. Okay, so these are the various methods which are available, but I would like to say that LPA has one inherent limitation, that mostly we use it only for smear positive cases, though the later versions are said to be sensitive even in smear negative samples. But primarily in the program we use LPA after only if it is smear positive. And so that in that cases, if the smears are negative, then we go for the liquid culture. Only from the liquid, once we have a positive in the liquid culture, then maybe subsequently LPA can be done. So if you see, at every level, liquid culture has its own role. So with this background, I would like to invite the other speakers and other to talk. Thank you.
So thank you, sir, and thank you for your brief introduction and your overview of TB diagnostics which you have given. Radha ma'am, I think we can now go on with the session.
Yes. Good evening, friends, and welcome to the first in the series of these webinars. And today's webinar marks an eve prior to the World TB Day, which is coming up on 24th March. And this is a wonderful initiative taken by BD and joined hands with Indian Chess Society, the Union, and the Central TB Division. And we have wonderful speakers with us. We have Dr. Chopra, we have Dr. Jyoti, we have Dr. Uma Ramesh, and of course, Camilla with us. So there would be small presentations from each one of them, and then we'll take up a few questions to clear the doubts, as well as to make the message reach to each and everyone who is logged into this webinar. And I'm sure this is going to be one of the best webinar series we have had on TB diagnostics. And having experienced people in this webinar as panelists and to answer the questions, I would appeal to the audience who has logged in to post their questions after the presentation so that they would know what they want to have clarity on which questions. So without making any further delays, has Dr. Chopra joined? Yes.
Yes,
So
yes,
we request Dr. Chopra, who is the director of the Delhi TB Center, to make his presentation on current scenario of tuberculosis in India. Dr. Chopra, please guide him to...
yes, ma'am, I think
Good afternoon. Good evening, ma'am. Thank you for this invite. Dr. Arun, can you share my slides? So that
your
can...
slides are already shared, sir. Yes, sir. You are also visible,
okay.
sir. Your first
But
slide is on.
Not visible to me.
You will have to go to your
right
slides and click on your slides, sir.
Okay.
As I was, go to slides and then click on. It's already on, sir.
Okay, great. Yes. Okay, my first presentation is from my side, that is TB scenario in India and what are the current challenges. As you can see in my name slide itself, that 27% of all the global burden of tuberculosis in India. Next slide, please.
Yes, sir.
Please.
Yes, so I'm discussing briefly about the TB incidence, then TB prevalence, and something about the epidemic as the program notification, what have been the trends. These are the notified TB cases during the last year, which shows that our total notification was 25,48,000, which comes out to be 92.2% of our target. You know, at national level, state level, and district level, target of notification is given based on the previous year's notification. So in total, during the year 2023, we expected 27,6,200 cases, out of which 92% were detected. And important point was in the public sector, we could achieve 93.4%, while in the private sector, our achievement was 90%. This is very good. During the last many years, this has been increasing. Private sector notification is reaching up to the 90% of the target. So diagnosed patient during this year was 25,48,000. And out of this, 96% patients were put on treatment. That maximum patients we could put on treatment, except for 4% which could not be produced. And during the year, 71% patients we could ensure the outcome also. And this outcome, out of this 54% outcome was updated on next year. So that shows 92% is overall case notification. 96% where patient has been put on treatment. Next, please. So this is the incidence of TB notified cases as per the age and sex distribution. We can see the maximum cases are in the age group of 15 to 45%. And in all the age group, except in younger age group, maximum male patients are there. So male patient and female ratio is around 60 to 40. And pediatric patient, around 6% patient has been found to be positive. So male patients were 15%. Patient, giving a ratio of 60 to 40. Next slide, please. So this is the incidence of notification by the type of case, pulmonary and extrapulmonary. Of late, we are finding more extrapulmonary cases. The ratio has come out to be around 24% extrapulmonary cases, and rest are the pulmonary cases. Previously, ratio was around 10 to 12%, which has gone up to 24% now. Regarding retreatment cases, retreatment or relapse cases have been increasing during the years. During the year 2023, 84% patients, they were new patients, and 8.9 were the retreatment cases. Next, please. So bacteriological status and UDST, bacteriological status, we want that there should be microbiological evidence of tuberculosis whenever we are diagnosing it, but in many types, especially in extrapulmonary cases, we are not able to showcase the bacterial evidence. Then we diagnose the patient based on the clinical presentation. So around 50% of the cases reported, they have come out to be clinically diagnosed, and in 50% we could do the microbiological confirmation. Advantage of getting bacterial confirmation is that we can do universal drug susceptibility testing. It means that we should know at least rifampicin resistance, and now this target has been increased that we should have at least rifampicin and fluoroquinolone resistance, so that we can diagnose the patient of MDR, PXDR at the time of diagnosis. So universal DSC is very important, but unfortunately during the year it was found that only 50% of patients we could do universal drug susceptibility testing. Next, please. So TB disease burden, if we come to see TB burden, as per the global report, estimated incidence rate of TB is 6 cases per 100,000 population. And estimated TB cases in 2002 total turned out to be 2.7 million. So we expected 2.7 million cases, out of which 2.42 were we could identify, and rest they remain missed cases. So missed cases are around 3.3 lakh patients still missing in our case notification. 2% of the total cases who are diagnosed, they are HIV positive. This is important because if a patient is HIV positive, patient is ART in addition to the antitubercular treatment. 2.8% found to be drug-resistant cases, and 65% they were in the reproductive age group of 15 to 45. Male to female ratio was 60 to 40. 6% were the children. Maximum cases were from the rural area, and say 9% were in the tribal area. Next slide, please. So this is the incidence of new and relapsed TB cases per lakh population. You see this is the ratio which has, this is the flow chart which shows that the number of cases which have been diagnosed and put on treatment, and gap between the two by the end of 2022, that has decreased. Next, please. So this is the incidence among HIV positive TB cases, and this is HIV TB cases, TB mortality. When we see the mortality, it was around 36 in the year 2010, which has decreased to 24 in the year 2022. And we have a target to decrease the mortality up to 3% per lakh of population by the end of 2025, as per the target of TB control program. Next slide, please. So this is the age and sex distribution. We have seen for the age group of the 5 to 14. So this is the cases attributed to 5 risk factors. This has been seen in our disease prevalence survey. There are 5 factors which have been defined at global and Indian level. That is undernourishment, alcohol use, smoking, diabetes, and HIV. In other developed countries, it has been seen that this program is TB burden is driven by the HIV, but it is not in the case of India. In India, maximum risk factor has been found to be undernourished. Alcohol use is second, smoking is third, diabetes is fourth, and HIV comes to be the last. So in India, most common risk factor for developing disease is undernourishment. Next slide, please. This is the trend in the estimated TB mortality. A number of cases which are dying because of tuberculosis, and it has been seen that by 2025 we want this mortality to be decreased to the level of 3%, 3 cases, 3 deaths per lakh population per year. Next slide, please. So this is situation of tuberculosis in India. A population which have been found to be 1,420 million. NTB strategy for milestone is we have to decrease the TB deaths. TB death has been decreased. Our base level is 2015. By the year of 2022, there has been 19% reduction in the TB deaths, but the target was 35%. We could not achieve the target, although there has been reduction. TB incidence reduction was also, target was 20% as compared to 2015. By 2020, there has been 16% reduction in the incidence of TB diseases. Next slide, please. So number of TB deaths, that one person every 2 minutes is dying because of tuberculosis. This is 3 42,000. As it has been seen, there has been decrease in the death rate by 6.6%. Similarly, TB death rate, the range is 70 to 32%. 24 deaths per lakh of population is occurring during the year 2022. So people newly diagnosed and reported, that is notified by the TB, that was 22 lakh in the year 2022. And this was increased by the 15%. In 2021, only 19 lakh and 65,000 patients were reported. That was because of the COVID era. In 2021, it was less, which has increased to 20 lakhs. WHO has recommended rapid diagnostic test, that is molecular test, and our national service showed that 33% of the people of newly diagnosed TB patients, they are using molecular test, while our target is almost all the patients should be diagnosed with the molecular test so that we can know the resistance factor at the start of treatment. Next slide, please. So this is the people started on treatment of TB preventive treatment. This is a new initiative. We cannot achieve the target of TB elimination if we do not give TB preventive treatment, because even if we are achieving 95% cure rate, we cannot achieve the target because infected population, which is around 34% in our country, they might be developing disease because of the infection. So people started on treatment. It was more than 1 lakh patient has been started on treatment during the year 2022. This is seen in the people living with HIV, contacts under 5 and contacts age 5 and above. Maximum cases are household contacts, and then comes the people living with HIV. People diagnosed with drug-resistant TB during 2020,000 was 64,000. So 64,000 patients was diagnosed during 2022 with MDR tuberculosis, which is 9.5% increase as compared to treatment for drug-resistant TB. This also, there was a 14% increase in 2022, 60,000. Out of 64,000, 60,000, that is around 90% patient we have been able to start treatment among drug-resistant cases. WHO recommended shorter regimen, which is the treatment of choice. Because of the shorter duration, more chances of success, and we can achieve 70 to 80% success rate. Unfortunately, only 35% patients could be put on the shorter regimen. Main reason of is this, the resistance to fluoroquinolone, which is coming in different states from 30 to 40%. In Delhi, we are getting more than 42% fluoroquinolone resistance, so that patient cannot be put on shorter regimen. Next slide, please. So this is the most proportion of TB cases with drug-resistant TB. Among new cases, it is 2.5%, and previously it is 13%. It is based on the National Drug Resistance Survey. Next slide, please. Next slide, please. So this is the NTP notification. It has been, notification has been increasing in the public sector and private sector both, but it is good that from private sector also we are getting a lot of notification. During the year 2022 till October, 8 lakh and 43 patients have been reported from the private sector as compared to 17 lakh patients from the private sector, public sector. So private sector notification has been increasing during the years. Next, please. So TB notification, what has been the data? So percentage of using rapid diagnostic test, that was 33%. Among 96% cases, we know the status of HIV among our notified patient. 75% patients are pulmonary, rest are extrapulmonary. Out of this, 64% are bacteriologically confirmed. 5% are the pediatric patients, and in females, above 15 inches. So total notified patient during 2022 was 24 lakh. Next, please. So this is the estimated incidence plus the cases which we are detecting. So in 22 as compared to 2015 target, there has been decrease of 18% incidence. It was 210 per lakh of population in 2021, and it has decreased to the level has decreased by the 18%. So TB notification is increasing. In 2022, 24.2 lakh patients were notified as compared to the expected of 29.5%. So 8.5 lakh missing cases in 2021 is also, they were the missing cases, which decreased to 17, which was 17.4 lakh patients in 2021. In 2015. So in 2015, 17.4 lakh patients were missing and 8.5 lakh were missing in 2021. We reached to additional 8.1 lakh cases as compared to 2015. So this has been increased during the year cases notified as per the MDG goals. Next slide, please. India's progress. This shows the India's progress as compared to estimated incidences. It is increasing, and as per the estimated, there has been a sustained increase in the notified cases, except for the year 2020 and 2021 because of the COVID. Next slide, please. So TB notification trend by public and private, there has been constant increase in the notification in the private sector. Even in 2023, half of the total patients which have been notified in India, they are from the private sector. Next slide, please. So regarding treatment success rate, among new and relapse cases, we have got 87% success rate. Among previously treated cases registered, it was 78% success rate. Drug-resistant cases, it was 69%. And pre-XDR patient, we already started 67% success rate, 64% success rate is achieved on the patient put on second-line drugs. Next, please. Regarding the prevalence of disease during all these years, next, please. So this is the prevalence. Disease National TB Prevalence Survey was conducted, and which showed that variation, there was wide variation in prevalence of disease per lakh of population from 137 in Gujarat to 747 in the Delhi area. So on the average, Indian average was 302 cases. These are the 312 prevalent cases per lakh population per year. And there is a wide variation among different states. The important findings were in all forms of TB, the prevalence was 312 per lakh population. If we found the microbiological confirmed, it was 316. Male to female ratio was 472 into 154. In older age, above 55 years, our prevalence was 588. It is much more than the adults population. 930 were the latent TB infection was found in 31%. So 31% they need treatment, 31%, and more in the persons with comorbidities. Among malnourished, it was 930 per lakh population. Among diabetes, it came up to be 511. Smokers, 853. Alcohol users, 72%. So basically, 31% patient are latent TB infection and they need TB preventive treatment. Next, please. Thank you. This was all in the brief about the burden of TB disease in India.
Thank you, sir. Ma'am.
Thank you, Dr. Chopra. That was a very well presented and exhaustive slides on what exactly are we facing. And what I could pick up, and I'm sure everybody who has logged in has picked up, is that though the private sector is contributing very well now in the notification, and this number is going to increase. However, whether it is a government sector or a private sector, most of the people are not being offered UDST. It's not only the WHO which has said, but it's also in the Indian guidelines that every patient who is diagnosed of tuberculosis, whether it is pulmonary or extrapulmonary, upfront CBNAT has to be, or any molecular test has to be offered, so that primarily we rule out, when we start treatment, at least rifampicin resistance is ruled out. And then there is an inbuilt cascade which looks at the samples and decides about the further tests which are to be done. So I'm sure all these things would be covered by our wonderful panelists who are going to make presentations. And now we have Dr. Jyoti, who is making a presentation. Dr. Jyoti is a professor of microbiology at Aurangabad, and I was fortunate to look into her work when at the COVID times. She really worked day and night and has truly contributed by her work. So she would be speaking on a rundown on TB diagnostic algorithms. Dr. Jyoti, are you around?
Yes, ma'am. Yes, ma'am.
Yes.
Good evening.
Good evening. And she's a wonderful and dedicated microbiologist. Jyoti, please go ahead with your presentation.
Yes. So a very good evening to all. And first of all, my acknowledgements to the organizers, to Dr. Radha Munje, to BD, for giving me this opportunity to discuss the algorithm which the National Tuberculosis Elimination Program has been implementing. And I, belonging to a government sector, have been implementing this particular algorithm for managing the TB cases. So without, the time allotted to me is 10 minutes. So I would just switch on to the slides so that we can discuss and I can finish on time. So this is my objective. So just to give an overview that the whole elimination program is structured beautifully, where we have got specimen collection centers, and we also have the NAT facilities where either CBNAT or TrueNAT, this molecular test is available. And this slide actually depicts that how the samples are collected at the health facility by the laboratory technician. So as you are aware, 2 specimens are collected. One is spot and the other is supervised in a Falcon tube, which is 50 ml, and it is transferred in the triple layered packaging. So once this patient's sample is taken, all the details are entered in the NICSHE, which is the portal for TB. Now, the whole algorithm will run in the modality where after the CBNAT sites work or the NAT sites work up on the sputum sample, the sample is resent to a higher center, that is a CNDST lab. So here, if the specimen shows an MTB detected or it is not detected, accordingly the sample is packaged, because even if it is detected, we need to test for INH. So you are aware that TrueNAT and CBNAT both are capable of detecting resistance to rifampicin, at least the conventional ones. I'm not talking about the newer modalities of CBNAT that have come. So this sample needs to be transported and sent to a higher center where resistance for INH will be detected. And once the sample is there at the culture DST laboratory, the further process flow moves on, where depending upon what the result at the CBNAT or the TrueNAT site has happened, the testing would follow. So I would be showing that in the algorithm, which has been developed by the NTEP. So just a quick overview that I would like to emphasize that the correct sample is very, very important. The details of the sample which is sent to higher centers or even at the collection centers, it is very, very important, because the concept of garbage in, garbage out is applicable very much here in the laboratory. All the details need to be properly matched, proper labeling. The container is to be properly filled, packed, and then it is to be sent appropriately into the higher center or wherever the transport is happening. Just a word that extrapulmonary samples need to be collected in sterile containers, and if required, a sterile saline, never any preservative or formalin is to be added. So just again, the test, I'm sure Camilla ma'am is going to discuss in detail about the various modalities, but these are the available tests that are being used in the NTEP for management of TB. The solid culture is, of course, no longer used, but at some places where there is crisis, sometimes we still look upon the solid culture for follow-up cases. So now coming to the overview, just an overview of how the sample flow happens. So once the smear microscopy is done, if the smear is positive, we can directly go for the line probe assay. The advantage being that both rifampicin and INH can be tested together. And once you get the valid results, you can go and report to the concerned health facility. When the smear is negative, it is not possible to do the line probe assay. So this I'm talking of the sputum sample, which has been referred by a NAT facility to a higher center where the molecular techniques like LPA and LCDST are available. If the smear is negative, then we need to perform the liquid culture, and the growth from the liquid culture is then used to perform the line probe assay, and wherever required, the LC-DST is also performed. So this is the basic thing, that a smear positive can directly go for an LPA. Smear negative, you will have to grow. And of course, all the smear negative samples which come to any laboratory, if they are sputum samples coming to a laboratory, if they are smear negative, they have to be put up on CBNAT first, and then they can be grown on the liquid culture laboratory to perform the other tests. Now coming to the main essence, the topic of understanding the diagnostic algorithms. So this algorithm is something which I would want you to understand very categorically, very clearly. So here we have three groups of cases. We could have a patient who is presumptive TB, and we have all the enlisted presumptive TB cases enumerated here. People living with HIV/AIDS. It could be extrapulmonary TB cases, smear negative with X-ray suggestive of TB. There could be a vulnerable population group or a contact patient of an DRTB. Then second group is the all notified patients, TB notified patients, and the third would be a non-responder to treatment. Now here we need to perform the NAT, either CBNAT or we have the true NAT which can be performed, and we go for the further processing. Yes, so we go for the further processing. So either we could have resistance, rifampicin resistance not detected. So here, if rifampicin resistance is not detected, then we still need to go for the first line LPA. Now, as I already mentioned, if the smear is positive, then it is easy to go for the first line LPA. If it is negative, we will have to put it up in the liquid culture, and from the culture, we will perform the first line LPA. Now, if the first line LPA, now I'm discussing the left side of the algorithm. If the first line LPA shows INH resistance detected, then we need to, either it will show not detected, that is fine. If it shows detected, then again we need to go for the second line LPA. Now, whenever INH resistance is detected, we have to perform drug sensitivity testing in the liquid culture for pyrazinamide. And based upon the results of second line LPA, we will go for further DST in the liquid culture. So here we will do DST for moxifloxacin and linezolid only if we have the fluoroquinolone or we have the pyrazinamide resistance detected. So this is the left side of the algorithm. Now we have on the right side, if it is NAT is showing us a rifampicin resistance, then here it is important that we still go for the first line LPA. Now again the same rule would follow, that if this is smear negative, then we need to grow it in the liquid culture medium, and we do the testing for INH resistance here. Here again, this is important that we are going to go for the second line LPA and also DST for moxifloxacin, linezolid, cefazolin, pyrazinamide, bedaquiline, and delamanide. Now here again, one needs to understand that not all labs are equipped for DST for all the drugs. So the commonest that is available is moxifloxacin and linezolid, and some of the higher laboratories are having bedaquiline, and of course pyrazinamide is present invariably. Bedaquiline, clofazimine, and bedaquiline, cefazolin, and delamanide are available in certain reference laboratories only. Now, again, the same description and the discussion I would like to put forward here is, so if rifampicin resistance is detected, then we need to go for the first line LPA and second line LPA for fluoroquinones and second line injectables. This is for the right arm of the algorithm, which we have I have already showed. So DST to all these drugs wherever it is available. Now the not detected rifampicin resistance not detected on CBNAT and TrueNAT, then we have the protocol of doing detecting for INH resistance, that is INH monoresistance we need to look for by performing the line probe assay. And if INH resistance is detected, then we need to go for the second line LPA and DST for the pyrazinamide. Now, if we have fluoroquinolone, INH and or pyrazinamide resistance, then we need to go for further DST to moxifloxacin and linezolid. So this is the algorithm, which is a combination along with the treatment modality that is given. So it is an integrated, same pattern is already mentioned, as I have already discussed with you. Now here only in addition, what is the kind of treatment regime that needs to be given to that particular group of patients is mentioned here. Very quickly, I will go through it. I'm sure somebody would be speaking in detail about the treatment in the further series in the lectures. So the left arm, where we said that resistance is not detected, we have the DSTB regime which is there. And after whether if INH resistance is detected, then accordingly the H mono poly DRTB regime is given. If still further resistance is detected, then there needs to be the replacement table needs to be used to manage that particular patient. On the left side, if resistance is detected and we are able to perform all the DST of all the drugs, then we have a choice of going for a shorter oral bedaquiline regime. Or now here, if we do not have an additional resistance for let's say we have no additional resistance, or we do have INH resistance detected with CATG or INH mutation, not both, that is important, and fluoroquine resistance not detected, then we can go ahead with the short oral bedaquiline regimen. On the other hand, if INH resistance is detected with both CATG and INH mutation, then we have the fluoroquine resistance detected. Also, or fluoroquine resistance detected, then we need to go for the larger oral MDR regime. So I would move to the next component of the algorithm for the DRTB diagnosis in children. So DRTB is usually from the source case, and less commonly it can result from previous inadequate TB treatment. And usually the children will mirror the DRTB in the adult. And the pointers of likelihood of DRTB in children are usually an epidemiological marker, that is the history and treatment details of the patient and or contact, or the child is non-responder to treatment. Now here, appropriate body fluids of both pulmonary or extrapulmonary TB need to be picked up from the child for mandatory bacteriological confirmation and the drug susceptibility testing. So sputum or other samples like gastric aspirate, induced sputum, bronchoscopic lavage, lymph node aspiration, CSF tissue biopsies may be collected in all children with presumed DRTB for NAT or LPA and culture and drug sensitivity testing. So this is the algorithm which mimics the one we have discussed. So it will mainly go on the source of the patient. So once we go in a process where we know that we know the DRT or the DST of this particular patient, if it is confirmed DSTB, then we treat it as DSTB. Now, if we do not know the DRT or the DST of the child, then we need to evaluate whether there has been contact with infectious patient. So we can again elaborate whether it is yes or no when we are not aware of the source of the DSTB, whether it is DSTB patient or there is no other risk factor. So we know that the source is a known DSTB, then probably we can start the DSTB therapy for the child. And here, I move to the central limb again here. If there is a contact with the infectious TB patient and we know that DRT, DST of the source patient is not known and the source is a retreatment TB patient and or a child is failing the first line of treatment, then you again assume that there is a presumptive DRTB case. So next step for both these, when there is a probable DSTB or a presumptive DRTB, we try to do a DRT or DST of the child or the source, whatever is available. And then as per whatever the results are showing, the treatment will move either to DRTB or DSTB. Now, on the extreme left side, if we know that it's a confirmed DRTB, then treat the child as DRTB. Now, if there is whether contact with infectious TB patient and the source is a DRTB case, then you treat it as a probable DRTB. We do a DRT or DST on an appropriate specimen from the child and consult a pediatrician for the further management of the child. Now, just a passing overview on all the laboratories that are running in the country have gone through a very stringent quality assurance program for giving the reliable results. And this structured quality assurance program, right from the sphere microscopy, there is a very strong linkage where the microscopy results are also run under EQA program by the NRLs and the state IRLs. And this management is done up to the DMCs also. Then the culture DST laboratories and the NRLs and IRLs all undergo a certification process, which is initiated from the NTP division. And even before the laboratory actually issues the first report, the whole process of pre-assessment, assessment, and the certification process is initiated, and this takes a pretty long time for the final go-ahead. Then the more addition of quality to all these laboratories is going for an NABL accreditation, which of course gives it more emphasis on all the participation in external quality assurance and also the daily IQC which is done. So there is an annual PT program which is run by the NRLs, and all the laboratories, both public and private, they are certified. So I think this is all I have to say because I was allotted 10 minutes of time. Thank you so much.
Thank you, Jyoti. And that was quite exhaustive. And first of all, my apologies. Now you are a professor of microbiology at the GMC of Sambhajinagar. It's by habit that I said it's Aurangabad. It's now termed as, named and addressed as Sambhajinagar. So that's first thing. Secondly, you have done a very elaborative job of explaining those diagnostic algorithms. And equally important is you have stressed so well on how the sample should be sent, and of course how the quality of the work done in laboratory or the laboratory itself is very, very important. And the inbuilt cascade in the program that once you receive a sample, a person need not put down that a culture is needed, because if you have sent a sample for LPA and if the sample is negative in the direct smear, the onus is on the laboratory to do a culture, primary culture first, and then do LPA in the growth when it is observed. So that has been so nicely explained to you. And we have now only 2 people left to make a presentation. And now we have with us Dr. Uma Ramesh, who would be speaking of liquid culture and DST, which are the gold standards in diagnosing and then, of course, the TB management. Yes. Dr. Uma is a senior lead microbiologist and is also an expert in molecular biology. She is working in ICS Diagnostics laboratories at Bangalore. Uma, you can take over from here. Can you hear me?
Yeah, I can hear you.
Yes.
Am I audible?
Yeah, ma'am.
Yes.
You're audible.
Very
Perfect.
good evening to everybody. At the onset, I'd like the organizers for giving me this opportunity. I'm very happy to be discussing on this topic, liquid culture, because this is very close to my heart. This is something that we do on a day-to-day basis. I work for a corporate, so we get a lot of cases from clients, customers, clinicians, patients walking in. So many a time they are not aware about the liquid culture and we have to educate them. And this is what we do all the time. But unfortunately, the expectation is quite challenging because they want an accurate result and they want a shorter TAT and they want it at a reasonable cost and it's very access to the report. So all this, there is no single test which ticks all these boxes. But like in the previous speaker had explained, the algorithm is very important and every test is important and a combination and algorithm will lead you to the diagnosis. But having said all that, a TB culture is very, very essential because for a microbiologist, a definite diagnosis is by culture. You are actually not only diagnosing, you are also telling whether the viability of the bacteria. Say, for example, if you do a molecular testing, you get a positive result, but you're not sure whether it is a dead bacilli or a live bacilli, which is why in a follow-up cases on TB treatment, you always do a culture test. You cannot go and do a molecular test because it will eventually come positive. So to know the viability, a culture is a must. And there are many cases, example, like the extrapulmonary cases where the quantity is not sufficient, where you have to decide between the two tests. I would always say it would be good to do a culture because if you get a culture positive, you can always go further for add-on testing of drug susceptibility. You can do a genotypic drug susceptibility or a phenotypic, the whole genome sequencing, LPA. You have a whole choice of tests what you can do. But the reason why I feel most of them shy away from the culture is basically because of the TAT. But we have come a long way from the animal inoculation to egg-based media. Then with the introduction of the liquid culture and all the CDC, WHO, and our national programs have endorsed the liquid culture. We did come up with for a short while with the radioactive cultures, but then it was a hazard to the environment and discarding became difficult. And then was introduced the midget tubes, which is now in use. And along with automation, it is one of the excellent tests. So what you need to know about the culture is it's not 6 to 8 weeks always. 6 to 8 weeks is the TAT for a negative culture. Normally we give 6 weeks, and certain cases where the smear is positive or an extrapulmonary sample, we keep it a little further, or in clinically suspected cases. But a positive culture would take approximately 2 weeks. But what we have seen in my experience, that if it is a 3+ sample of sputum where the bacillary load is more, we have got as early as 1 week also. Okay, and then once the culture is flagged positive, we inform to the clinicians that it has been positive and to do the further testing of DST or whatever can be done. And identification is given on the same day. But many of them get apprehensive because they come back after 8 weeks not knowing that. So what we do is we normally give a preliminary report at the end of 3 weeks to keep them informed about the status of the culture. So this is the midget culture. It also comes in a different smaller size of 320. What we have is the midget 960. It is so called because of the microbacterial growth indicator tube. It is much faster than the others because we have add additional antibiotics to overcome the contaminants or commensals that may be there. And also additional growth factors is added. That's why the culture is much faster. Previously, when we had the solid culture, we used to take a reading of about 1 week, but this instrument takes a reading every hour. And we need not check every day for the positivity. There is an alarm whenever there is a positive culture, so it's easy to identify the tube and immediately process it. The advantage is that it's a non-radioactive substance, so discard is not a problem. But only thing, I wouldn't say it's a disadvantage, but it is for the safety of everyone. This culture is not done in every laboratory. You need to have a level 3 laboratory where you have a negative culture, you have the PPE, and you also have cooling centrifuge and the biosafety level 2, where the entire air is discarded out into the environment. And a positive culture that you get carries almost more than 1 lakh colony forming units per ml of the sample. So this is quite sufficient for you to do any add-on test. So I would say the one thing what was already emphasized previously by the other speakers, a site-specific sample, garbage in, garbage out, that is what doctor said. I totally agree with you. A site-specific sample is what is essential for culture. So the sensitivity, it's just a comparison, and you can detect up to 10 to 100 bacilli from the sample. So the culture isolate, once you get a positive culture, what are you going to do it? You can do a ZN smear. You can identify it immediately with MPT64, which is like a immunochromatographic test, or you could do directly a molecular test, or you can do a sequencing, you can do the phenotypic test, you can do the genotypic test, you can do the whole genome sequencing, and you store the isolate for longer with you, so that in case the treatment fails and you want to retest it, you can revive the culture and do the other additional tests. And definitely it will be useful for the epidemiological studies as well. The drug susceptibility test, yes, we do have drugs which are tests which can tell you immediately, but when you say phenotypic test, which is where you do on growth, or this is done in the midget instrument, where you take 2 tubes, one with the drug, one without the drug, and then you load it and you compare the growth factor. Once the growth factor reaches in the control tube, then the reading is taken. For the first line drugs, you get an automatic reading. For the second line, you can take the drug reading. An approximate TAT for this is around 13 to 14 days. So like I said, how do you convey it? It's good to do that test. It's an automated test. It's you get a good result in a shorter time, but unless and until you convey it to the clinician, it is of no use to them. So first and foremost, it is the duty of the doctor or the laboratory to inform the clinician about the positive report. So what we do is we take the email ID, and as soon as the report is ready, we auto-generated email goes to the patient or the doctor. And we also have a SMS option where when the report is ready, we send the alert to the patient. This is done automatically. Of course, it will not be possible for us to do individually. It is auto-generated. And you can tag as many people as you want, the doctor and the patient. And of course, nothing like discussing directly with the microbiologist. This, like I said, you are doing a combination of tests. There's always a possibility that there may be some discordance between both the reports, be it a genotypic and a phenotypic. Then you have to analyze, and there is always a reasonable explanation. Sometimes the PCR could be positive and a culture negative. This could be maybe because the patient is already on treatment, or the sample is deteriorated, or it is a dead bacilli. And the reverse can also happen, where a PCR is negative and a culture is positive. So in those cases, there's a possibility that there could be PCR inhibitors in the sample, or it may not be a site-specific sample, or certain requirements like the salt content could be higher. So these are some things you have to analyze together to come to a conclusion. So I always say the site-specific sample, the report is as good as a sample that is submitted. And this has already been emphasized. You need a test request form. You need that history to update in the NICSHare portal. You need to give a good sample, follow the guidelines of proper collection, sufficient sample, good sample, and transport to the laboratory immediately without addition of formalin. Yes, this is applicable to all the samples. When you cannot identify the sample, or the sample is in formalin or collected on a swab, the swab is dry and it's not a site-specific sample, or the sample is more than 24 hours, blood, all the samples can be processed on midget except blood sample, for which you have a different instrument, which is not discussed in this. You could do a BACTEC, there's another instrument, fluorescent technology, where you load it into the BACTEC instrument. The quality not sufficient. These are all leaking sample, broken containers. These are all the rejection criteria where we do not accept the sample. So the emphasis, again, I would say, is culture is mandatory for all samples, all clinical samples suspected of tuberculosis. All the samples that are being submitted for molecular test, and whenever the culture is positive, a DST should follow for it. And with a short amount of time, I'm able to hope convey what I'm trying to say about the liquid culture. Thank you.
Thank you, Dr. Uma. That was wonderful. And what I found common was that you and Jyoti insisted on the quality of sample, the way it is being transported, it is packed, it's labeled, not labeled, and all that. So we must emphasize this because, like the sample is sent, and if it's not processed, it's first like we are asking everybody to do UDST or use genotypic methods to diagnose and put patients on treatment as earlier. And then if they don't get a report, a wrong message goes, or probably what we say that misunderstandings are created. So it's important for not only the patient to know, but also for all the doctors to know how they should be instructing their patients. So this has been very good. And what you talked about, automated reports going to the mobile as message as well as email is also one good thing, so that the delay between is prevented. Like you get a report, but or the report is ready in the laboratory, but it doesn't reach the patient or the treating doctor. Even that delay is not acceptable. So this is also one good thing that you told. And now we will go ahead with Dr. Camilla's presentation. And when I say this, she doesn't need introduction. It's not what everybody talks about everybody. It's very true that Camilla really does not need any introduction on any platform. And she would be now making a presentation on these diagnostics. And I'm sure she would also touch on the advancements which are happening in the laboratory diagnosis of tuberculosis. Camilla, you can take over, and the team, please help us share the slides.
Sure, I think slides are now visible.
Yes. Can you hear?
Yes, ma'am, you're audible.
Yes. Camilla?
Your video's on. I'm not able to see you.
Yes, she's there.
She's there. I'm able to hear her voice. Camilla, ma'am?
Can you just load her slides first?
Slides are loaded, ma'am. It is visible now.
Okay.
You can click
Wonderful.
on slides. It's already loaded, ma'am.
Wonderful. Wonderful.
Camilla, ma'am? you able to hear us?
Ask the team to call her so that.
Yeah. Nitin, can you just check out?
Yeah.
And till Camilla takes up, let me tell the audience and all those who have logged in. By this time, we have 40 plus questions already posted. I would ask everybody to post more because we have enough time on hands, and all my panelists are very much dedicated and they would take up all the questions. I would request my panelists to bear with us even if we shoot beyond the time, and team BD to support us also if we overshoot the time, because we do not want any of the questions to go unanswered. Is
Sure,
that
ma'am.
right?
Sure, ma'am.
Yes.
We are okay with it.
Arun, can you hear me? Madam,
Yes.
can you hear me? Yeah.
Yes.
I can't see my
ma'am.
slides. Can you?
Ma'am,
I don't know
you
why
can go
my
to
voice-
slides, ma'am. After video bridge, you can
I'm
go to
going
slides.
yeah, sure. I've gone there. Can you see the slides?
We have
Yes,
slides
we
are
can
visible,
see.
ma'am.
Okay, fine. So friends, thank you very much for this. I'm going to really rush through this because I think you all are tired. So, ouch. Yeah. Okay. So my topic is update on TB diagnostic tools. And I think we need to owe a huge debt to Robert Koch, and we celebrate World TB Day on the day that he actually announced to the Berlin Physiological Society that he had discovered the cause of TB. And yet, despite all he did, testing still seems to be a weak link in TB care. From smear microscopy to molecular methods, remember that just 1 in 3 patients are bacteriologically confirmed world over, and sad that only 1 in 3 with DRTB are put on treatment. So there's this unsustainable anachronism of TB diagnosis, and really it's the diagnostic gap that precludes patients from accessing continuum of care. And Soumya actually wrote this with Madhu, and it's so pertinent because it tells you that we need to be, why we are failing is possibly because we need to get much closer to our patients. We need to look at lower costs for higher volumes, and we need to get something that is possibly LMIC manufactured. And to this end, can we get rapid diagnostics to the last mile? India is doing a huge amount. ICMR is flooded with good in-house Indian manufacturers that are doing, and this is something that a lot of evaluation is going on. It's really tiny, it's easy to use, it can be put out in a village, no pre-processing, but it's not yet not endorsed. So we need to wait for this to happen for the last mile. So this is my overview. So just to sort of look at the TB diagnostic pipeline today, and I think it's really true when we say, I think it was Lenin who said that there are decades when nothing happens and weeks when decades happen. And that really applies to TB diagnostics. And if you look at the WHO, this is Daniela's slide, just to show you from 2008 to 2024, there's so much activity. It's really so exciting. And as Dr. Nishant said, 2 days ago, the version 3 or the volume 3 of the TB diagnostics was released. It's really an exciting document. So the diagnostics that I'm talking today, we've discussed about liquid culture, etc. But if you look at the dynamic continuum of TB, it really sort of puts into focus that TB drives a paradigm of near perfect host-parasite relationship. So why should we do microscopy? One is clearly it's part of our program that says you must have something in place initially for bacteriologic to confirm TB, a bacteriological confirmed diagnosis. And we do FM because it detects 10% more TB cases than light. And what about liquid culture? This was done many moons ago. We did this study where we showed that there was clearly an improved TAT and improved isolation with TB midget, 9 days for pulmonary versus 33 days. And for EPTB, it was 13 days versus 37 days. So clearly faster and better. And this is just a snapshot of the WHO-approved diagnostic tests, DST tests that are available today. And as you can see, it's really grown hugely. But there are limitations of the DST. One is, I believe, is testing at a single critical concentration. And this paper we put out a year or two ago with the European Society, which said that the critical concentration of rifampicin was actually set too high. And likewise for levofloxacin, Cana, Mica, and ethambutol, and this actually resulted in a systemic misclassification of a proportion of resistance as S. And in microbiological parlance, this is known as a very major error. It's been sorted today, and WHO has actually given completely new critical concentrations and clinical breakpoints. And we actually looked at almost 7,000 isolates by the Cryptic Consortium. We did 7,000 in India, and we found that could we actually move to MIC testing on broth microdilution for anti-TB drugs in a routine diagnostic TB lab? Difficult, because a lot of standardization is required. And as of now, I don't think it's ready for prime time. So clearly, it's time to usher in a new era, and really rapid and diagnostic diagnosis is fundamental. But to be impactful, we need to directly perform susceptibility or resistance testing on clinical samples. And this is why it's possible, because we know the drug targets. TB is a Khandani organism, as I say, because it's not an organism that resistance is transmitted by plasmids. It's all in the chromosome, and we are defining the drug-resistant targets. And like I said, molecular diagnosis has its ace because it can be directly done on clinical samples. And I've made this little sort of triangle to show you how the WHO has actually defined low complexity tests, moderate complexity tests, and higher tests more than that. So the limitations of CBNAT and TrueNAT are one, it can't tell you where the resistance, what the mutation is. It's unable to pick up INH monoresistance. It's not that great in paucibacillary disease. I'm talking here about G4, that is the old CBNAT. It's imperfect for RIF resistance, as I'll talk in a minute. And of course, if you have something outside the RPO beta, it's a synonymous mutation, you may not pick it up. Okay, so yeah, so the difference is what Cepheid did, it brought in the Expert Ultra, which has really a better LOD, a limit of detection to 16 or 18. There's an issue of trace calls that I'll talk in a minute, but it's done better than Expert G4 in terms of RIF resistance, in terms of specificity, because it's actually, once you get a low load, the Ultra just tells you, sorry, it's indeterminate, I don't know. So the lessons we've learned were, what does MTB detected mean? MTB detected means it could be MTB as well as M. bovis and another 4 or 5, but M. bovis we need to keep in mind, especially M. bovis BCG in little kids who come to us with abscesses. What does MTB trace in Ultra imply? How do we understand RIF resistance? And does RIF resistance not detected mean drug susceptible? So a couple of slides, 2 slides on what is trace. I would really urge you to read this excellent study that is done by the European Society, published 2 years ago, which actually decided that when they got trace, they said, you know what, should we regard all trace as negative? And they found that they were missing a lot of real TB. What if we would say trace is negative, regard trace as negative in patients with past history of TB? They found that there would be a decrease in specificity. And what if we repeated the same test or did another Ultra on a new sample, and they found there was a decrease in sensitivity? So what they concluded was, you must have a good pre-test prevalence for TB and avoid performing Ultra on patients where the diagnosis of TB is actually excluded. And finding balance between overtreatment and the detection of paucibacillary with Ultra, they found in high burden cases, we're kind of not so sure if you get a trace in a history of prior disease, and treatment initiation should include predictors of active disease, and clinical presentation is terribly important here. In low burden countries such as Europe and the US, trace is considered to be treated. What about understanding RIF resistance? This was the case that I just wanted to dwell on, which we found. We had a patient who had a lymph node biopsy and a BAL the same day. Same patient, same day, different sample, different reports. And this was years ago. This was, I think, maybe 5-6 years ago. And you can see MTB detected very low. Both had very low loads. The same patient, mind you, had RIF resistance not detected and RIF resistance detected. So what we did, we went ahead and actually did a study where we found wherever we were getting detected very low on the G4, we looked at really were they resistance, and we found that there was indeed an issue of false RIF resistance because of unstable hybrids. And we feel that ideally labs should report RIF resistance in MTB detected very low as RIF indeterminate, as RIF resistance indeterminate, especially when the pre-test probability of rifampicin resistance is low. If you're not suspecting MDR at all and this MTB detected very low shows RIF resistance, I think we need to think again and wait for culture. We actually wrote this out in IJTLD again with Claudio, etc. And we published this study in Lung India. So we've dwelt on when RIF is susceptible, what about INH? We really need to solve this neglected problem. And let's look at other issues in the algorithm or in this chart. Expert XDR is a reflex testing for additional resistance. It's nice because it's fast and it can be done on the same expert machines with a little tweaking of the infrastructure. It can tell you low-level resistance. It can tell you for INH, it can tell you low-level resistance for fluoroquinolones, and it can tell you whether CANA is susceptible or not, depending on the EIS mutation. Now, the other group of tests is moderate complexity, and our program that Jyoti discussed really well is excellent because it actually addresses INH monoresistance when RIF resistance is not detected. So all these TB patients who come to you are actually able to pick up whether INH resistance is there or not. Okay, and it reconfirms RIF resistance and rules out INH monoresistance, and we then subject. We actually do LPAs for second line, and as Jyoti has told you, other drugs as well. And we have this nice chart that tells you when you see this, when you see, when we report out INH, this is how labs should report to the clinician. So they understand if it's a mutant one, you can actually look at if ethionomide can be given. If it's a INH one, you can look at whether INH can be continued at a high dose, but ethionomide cannot be given. And if both are there, neither of them can be given, and so on and so forth. But now, the limitations of LPA are clearly, it doesn't work well for smear negative. We tweak it a bit and we try, but it's about 50-60% we get good results. Again, the important point is that it requires manual interpretation, and the inability to detect all the SNPs responsible for resistance is one of the failings of LPA. So WHO has actually classified moderate complexity automated NATs, which include 3 new tests. One is the BDMAX, one is the Roche, and the other is the Abbott real-time. BDMAX actually detects MTB, both targets that are looked at in ultra, as well as RIF and INH resistance. It can be batch done, and it's semi-random. Our program still hasn't included this, and we're possibly looking at studies how to enable this to happen. So if you look at the analytical sensitivity of some genomic tests, expert MTB RIF, that is the G4, has 113 CFU. Ultra is much better because it looks for insertion sequences that are repeated several times. The problem with Ultra is sometimes it gives you MTB detected, but RIF resistance indeterminate. That's because it needs more bacteria for RIF resistance to be picked up, because it's only one area of the RPO beta. The LPA both need about 160, 150. Pyrosequencing and targeted NGS, which I'll talk about in a minute, is the next. So we've come this far. Do we really need next generation tests for TB? And if you look at pyrosequencing, we found we do need to sort of slowly start to integrate genomics into TB management. It's much more comprehensive detection of drug resistance, and clearly surveillance is required to optimize our programmatic regimens. We find that pyrosequencing really does well somehow. I have no explanation why it does particularly well for TB meningitis, but it does. And I'm quickly going to go over a case. This was a 5-year-old little girl, Tanu Singhal's case, who had fever for a month to demonstrate the issues and problems we face in TB. She had fever for a month, no other symptoms. She had the contrast-enhanced CT showed she had necrotic mediastinal nodes, and just a family history of 2 members of her family who had died from TB after long-term treatment. That made us suspect whether it was indeed drug resistant, but there was no other history. It was not possible. So we had this little girl, who was a TB suspect, query drug-resistant contact. What should we treat her with? It was not possible to do a EBUS open biopsy because of the various issues that I've listed here. So we decided to just watch. We started her on empiric treatment, and luckily 3 weeks later, she threw a supraclavicular lymph node, which was biopsyable. Histopath was done, expert was done, pyrosequencing was done, and TB culture was done. And imagine our horror when we found the pyrosequencing showed resistance to everything. 2 months later, the culture grew out. Expert showed resistance, and the midget actually bore out exactly the same susceptibility as the pyrosequencing, that she was the old XDR. But guess what? She was clinically fine. There was no fever. She had started gaining weight. There was radiologic improvement. So everybody was saying, you know, we have all these reports, strange reports, but look at our child. She's afebrile. The parents didn't believe the reports. Even the clinicians were doubting it. So anyway, it was decided, since she was doing well, let's wait. They were educated people, so we could afford to wait. So it was decided to continue her on first-line drugs for 12 months. She did really well till month 10 when the fever restarted. Persistent and increasing in intensity, weight loss, and the CT now started showing disease progression again. Luckily, we had a salvage regime ready for her, and she was started, and in 4 weeks, she was stabilized. So this is sometimes what happens, that you have heteroresistance, and the only way we can actually pick it up and see it clearly is from an LJ slant, where you can see there are two distinct TB colonies, where we actually have to do two different, either you do pyrosequencing or you pick it up and run it through expert and find two different results. Now let's look at targeted NGS. Whole genome, there's this whole argument about whole genome versus targeted NGS. Targeted NGS or targeted next-gen sequencing is the buzzword today. It has a much faster turnaround time, and we're actually doing it from patients. We haven't yet started formally, but this is done on research projects, where we see a faster turnaround time in 2 to 3 days of giving a smear-positive sample. How cool is that? So you have a sick patient. In 3 days, we'll give you entire 14-drug DST that's done by mutations. And we actually did this study on end-to-end sequencing with FIND, and we evaluated these 3 platforms, 18 genes, 16 genes, and 13 genes. And on the basis of this, 2 days ago, WHO endorsed this. They had actually initially endorsed it in July, gave a rapid communication, but they said, yes, you can use this technology, and it has been endorsed today. And this is the studies that have shown, this was us, where we actually offered 800 drug-resistant patients. So Dplex has been actually approved by WHO, as has Nanopore. And it depends how comfortable you are with these technologies to start. And I'm going to end with this case. A 26-year-old doctor. I've shown it before on platforms, but it really affected me, this case, because she was a doctor. She had received various first-line and second-line drugs in the recent past, including clofazimine. Sputum expert, obviously, with this ghastly X-ray, showed RIF resistance detected. She was really sick, severely breathless, cough, high-grade fever. And you can see the LPA showed that she was indeed pre-XDR. But she was really sick, and there was nothing we could do for her. So we ran a targeted NGS, and as you can see, this was her pattern. And whatever is red is what you can't give. So she was actually only so-called susceptible because resistant mutations were not found for linezolid, ethionamide, and second-line injectable. She'd been on BDQ, so she was resistant to BDQ as well. And not only that, we could see that whether she had potential mixed infection, which she didn't, and we could look at the lineage, which said that she was indeed a Beijing genotype. And this was borne out 40 days later on her midget, that she was practically resistant to everything except linezolid, ethionamide, and second-line injectables. And sadly, this young girl of 24, this young doctor of 24, was so fed up of 3 years of treatment that she refused to take the treatment that we offered. And we used to talk to her on the phone. After coming to us, she closed herself in her room and she said, I'm not taking any medication because the drug side effects are so challenging. And within 2 months, she had died. We had put her on in contact with so many TB survivors in Delhi, all over the country, but she refused to take treatment. So just to sort of go back to the topic that I was given, the factors that fuel the ravages of TB or chinks in our armor include not only environment and social challenges, that is AQI, malnutrition, alcoholism, diabetes, stigma of TB, but adverse drug effects that really preclude adherence. And I'm going to end there saying that this is just a chart that sort of puts into perspective all these technologies. But look at the cost. These are costs in the private sector. Of course, in the public sector, they are free up until here. The public sector does expert and ultra, expert G4 and LPA. This can be done at some private settings, pyrosequencing. But look at the costs. They're huge. So we have to have a way by which we overcome these costs, get World Bank or whoever to drop the cost so that we can give out results. Because I truly believe with drug-resistant TB, you have one chance, and we can't blow it anymore. Thank you.
So thank you, ma'am.
Kamila.
Yes, ma'am. Yeah, ma'am.
Yes.
Please go on.
Thank you, Camilla. That was a wonderful presentation. And what I could get, I mean, everybody got so much from her presentation, but what I could get was that if you really have a microbiologist to whom you can talk, and a microbiologist who can convey to the treating doctor what should be his choice, like ethionamide can be given but not INH. So a clinician would be so well guided that patients would definitely be benefited for the best possible outcome. And not only the presentation but the publication, whatever what I could get as a clinician and as a teacher from Camilla's presentation is that whatever abnormal or something which had a dilemma or posed a question was seen in her laboratory, she looked into that and came up with the solutions and publications which are now available for us to go through and make use of whenever we need to do that for our own patients, or when we are in a diagnostic dilemma, as she explained about traces of AFB seen and then how the rifampicin resistance has to be interpreted. And she underlined that equally important is the clinical scenario of that particular patient. Has the patient been symptomatic? What does the radiology show? Is there a very strong clinical suspicion that this is tuberculosis? And how would you interpret? And if there is no suspicion and just a sample is sent, because all other samples have been taken either for efficacy or biopsy, and perhaps this may not be tubercular. Thank you, Camilla, for reiterating that and explaining it so well. And now we will be going to our panelists with few questions. We have a good number of questions which have come up, and I think we'll go ahead with that. So the
request all
first question,
panelists to come on camera.
Yes, everybody please put on your video and yes, and whenever you answer we should be able to hear you, so please look into that you unmute as soon as you start answering the question. So the first question I think would go to Dr. Uma, and that is, even though we are adding penta drugs, why is there a contamination grown in the cultures?
Yeah, because the samples that we collect could be sputum. They are not sterile samples. If you get a sterile sample like a body fluid or a CSF, there is no chances of contamination. But you take a sample from the sputum, it has so much of normal commensals. So we need to treat before loading into the instrument. We digest the mucolytic agents, then we decontaminate, and we also concentrate before loading inside. But what happens is, if the decontamination process is very harsh, then it could affect the isolation also, the mycobacteria also. So it is a very critical balance. So we need to be do it very carefully, and about 3 to 5% is definitely accepted in a liquid culture. So you cannot make it very harsh either. We have to take care that the bacilli doesn't die in the process.
Okay. Thank you, Uma. And I have never seen a microbiologist growing so soft on AFBs also. Thank you. And that question had come from Mr. Shrikant Kasarneni. And we have now the other question coming up is, if CAT-G is resistant, then we cannot use high-dose INH, which implies we can't use a shorter oral bedaquiline regime. I think this question can be taken up by Camilla, because I'm not aware if there are any more explanation has come on this. So they want to know that we can't use shorter oral bedaquiline regime, but it was given in the PMDT program that we can start a shorter bedaquiline regime, and this needs a clarification. This question has come from one of the medical colleges SRM by Dr. Mona.
It's high dose INH cannot be given when there is a CAT-G. It doesn't mean you can't give short course. I think Madam Munje will definitely clarify. You can go on to another sort of, you needn't include high dose INH in your regime. We had actually published a study where we looked at Mumbai. Mumbai is a hotspot, And we actually found that almost 85% of our PXDR patients, who actually constitute 60% of our MDR, were not eligible for the short course regimen because we couldn't even give them fluoroquinolones, because the fluoroquinolones again are subject to the mutant 3B and 3C. You can't give moxi, and most of our mutations for fluoroquinolones incidentally were those. So, you can glean so much truth from your LPA results to treat your patients. So we found that as BPAL comes into regime and the country is thinking of giving BPAL-M, we can't even think of giving BPAL-M in Mumbai, at least for the patients who come to us. And we could just, we looked at how many patients it sequentially would qualify in our private sector, and it was something like 3. 3 out of almost 450 in that year would qualify for BPAL-M. But BPAL is a good regimen that we need to look at.
This question I would put in for open, because now we see, at least I come across very few pediatric cases. Dr. Abhishek from AIIMS Nagpur has asked, what is the proportion of bacteriological confirmed cases in the pediatric age group? Dr. Chopra, do you have some estimates of this? Because as far as I know, there are, I think, less than 20% of them are either confirmed in pediatric age group. Do you have any
figures?
Yes,
ma'am, it is less than 20%, but it depends on the, am I audible, ma'am?
Yes, very well.
Yeah, but it depends on the sample which is being tested. Like in many cases, in many institutes, like we see in Kalavati Medical College, Lady Hardinge Medical College, percentage goes up to 33%, of up to even to 40% when they take the samples, that gastric lavage, gastric aspirate. Even they are using the pooling of samples. They take 2-3 samples, gastric aspirate, gastric lavage, then 3 samples are pooled and getting results. In one study, we get up to 40% of results conducted in Lady Hardinge Medical College. But in general, it is around 20%.
Thank you. This question goes to Dr. Jyoti. Do you have any? Do you have any data on comparison between Gene Expert and LPA for diagnosis of MDR and XDR? I mean, he probably wants to talk about Gene Expert, XDR cartridges and LPA.
Yeah. No, so comparison between Gene Expert and LPA for diagnosis of MDR and XDR, that is what probably the question means.
Yes.
So Gene Expert, the plain Gene Expert will detect an MDR, but XDR won't be detected. So you need to have a Gene Expert Ultra for it. And as far as LPA is there, yes, LPA would have an added advantage. We have both first line and second line LPA. So first line LPA will be able to detect an MDR. And of course, the limitation with LPA will be always underlying that the smear positivity, or then wait for the growth of the midget and then do an LPA. So turnaround time will be different for Gene Expert and LPA, drastically different. And LPA second line will be able to detect the XDR. So I think these are all different limbs of the algorithm or the pattern we will have to follow based upon, what your findings are. So as such, comparison for turnaround time, there would be a lot of difference, but I don't have the data to actually.
Actually, this was a question asked by Dr. Anjali from Aureus Institute of Medical Sciences. The comparison was, we were just talking about the diagnostic efficacy and not about the turnaround time or even the cost effectiveness, because it has not been placed in the question. But yes, Gene Expert, what we term as MTB RIF and LPA, is very well able to detect MDR or diagnose MDR TB. And LPA can be performed only if the direct smear is positive. Otherwise, you need to have primary cultures. And if you want to diagnose XDR, then you would need primary cultures, and then you would be doing the DST on by our traditional methods. And if you want to diagnose it by Gene Expert, then you need to have that Gene Expert XDR software and the cartridges. Am I right, Camilla? Did I make a mistake, or did I put my leg into the microbiologist domain? We can't hear you, Camilla.
Camilla, you're on mute, I think.
Okay.
Yeah.
Okay. So we'll take the other questions. Yes.
I think Camilla ma'am is not audible. Yeah. Yeah, ma'am, you can go on.
Hello.
Yeah, no, Elsa.
Yeah, Madam was right only. Yeah, well, the XDR cartridge is the one which can detect the other drugs, second-line drugs, if we have to do by CBNAT or Gene Expert. And that too, for that, a specific 10-color, the latest Gene Expert 10-color system is needed. The most centers initially might have been having the 6-color system, so that may not be able to support the XDR cartridges. So that might be one point to be kept in mind.
So we'll go to the other questions. Just a moment. Yes. Then there is another question which I would be addressing to Dr. Chopra. Minimum period for development of TB disease after exposure to an open case.
So usually we say it is 6 to 8 weeks. It takes 6 to 8 weeks minimum time to develop disease after exposure. During which cell-mediated immunity increases, and that leads to inflammation and the progression of disease.
Right. Then this question is asked by Dr. Dhruvi Sankar from Konasima Institute, and she says that does INH prophylaxis lead to increase in H-resistant cases?
Hasn't been proved, ma'am. Hasn't been proved.
It hasn't been proved, right?
Yeah. And ma'am, I don't know what happened. You couldn't hear me. But just to tell you, we had done a study with the program where we looked at 300 samples of XDR on the XDR cartridge, and the same samples were subject to LPA, and we found that they were equally efficacious.
Okay. This question has come from Dr. Ajinkya Rajan Nimbalkar from Chintamani Hospital, and he wanted to know what are the diagnostic measures in routine practice for TB abdomen. I'm sure it would be coming up in the forthcoming webinars, but since this is a diagnostic webinar dedicated to diagnosis, anybody can take up that question. Uma, would you like to take this up? We can't hear you.
What is the question again, ma'am?
TB abdomen diagnostic measures in routine practice.
Well, I think, like I said again, a site-specific sample is what we would require. So if there was a biopsy done, nothing like it, no other sample other than that, be it blood, sputum, nothing will help in this case at all. So you need to have a site-specific. A biopsy would be the best sample here.
Yes. And what I would add to this is that even if a person is suspected to have tuberculosis of abdomen, doing a chest X-ray is mandatory to see whether they have either associated pulmonary TB or evidence of TB elsewhere. And then, of course, site-specific samples. So if it is ascites, the ascitic fluid can be taken, whether it is an intestine biopsy from the intestine, because now we have so many diagnostic modalities like colonoscopy is done, gastroscopy is done, and we see rare presentations of all different systems with present having tuberculosis. So site-specific sample is very important, and that sample must be kept in the normal saline and not in formalin, as is the habit with all surgeons. So That is very important that 2 different samples have to be taken. One in formalin and the second is normal saline, and a well-labeled sample has to be sent to the laboratory, which would be then offering further diagnostics.
Yes, madam. Not only in extrapulmonary TB, so not only in abdominal TB, the program says that in all the extrapulmonary TB cases, the clinician should make every effort to screen for pulmonary TB. That is a mandate as per the guidelines also. All
Yes.
extrapulmonary TB should be screened for pulmonary TB as well.
Yes. Just a moment. I'm catching on the questions. They want a comment from Dr. Chopra that Dr. Richa Thakkar is asking that is there an upward trend of population of positive adult contacts as compared to previous years, in though it has decreased in PLHIVs?
No, in adolescent age group or adults, we do not have any evidence on either.
Okay. So probably what
Ambulance
they
survey
have
shows
observed from the
31.4.
figure is that after COVID, the
31.4%.
notification is increasing.
That is
probably,
because during the COVID period, people were not reaching to the public health facilities to get diagnosis done. That is why the cases have increased.
Okay. Then this is a question which I think I would give forth to Jyoti. This has come from Dr. Sanjay Narayan Swami from Ramaya Hospital. If there is an option to choose between Gene Expert and TrueNat, which is the best in terms of sensitivity and specificity?
Would it be right to comment by experience? Yes, CBNAT has always been better for both MTB detection and RIF resistance also. So the issue with TrueNat, yes, it is a little more demanding as far as the technicality is there. A little error here and there, we end up with getting invalid result or indeterminate results. And RIF resistance component is, of course, better sensitive with the CBNAT.
Just one more point from my end, if I'm allowed to talk. Yeah, I think I'm sorry, one more point from my end regarding the same question. So I think it again depends on the limit of detection, the number of bacilli which each test detects. I think it also depends upon the which we are detecting. I think bringing in Gene Expert, TrueNat, and BDMAX, which is now coming up, each has its own limit of detection and the type of genes which they identify. So I think based on that, it's not a direct comparison, but again, we have XDR cartridge and Ultra in Gene Expert. We have a reflex testing which has to be done in TrueNat for the additional test. And BDMAX gives you INH and RIF at the same time. So each has its own advantages and disadvantages. So difficult to pick up. Again, it depends upon the load, depends upon what you're identifying. But I think all of them give the MTB complex positive or negative. That's the most common thing which is there in all the three. Thank you.
Yes. Okay. Thank you. Can you help me to see the question? It cannot seen completely.
Ma'am, you can just click on the enlarge button, ma'am. The second, after auto refresh, there are 2 more buttons. There's a full screen Q&A. You'll be able to see the whole thing in the full screen, ma'am. You're able to see that, ma'am. After auto refresh, you're able to see the 2 arrow mark and then in full screen view.
I cannot see that.
Or you want me to send can I just send it on your WhatsApp, ma'am, if you're okay with it?
That would be.
I'll just send it across.
Because we have a good number of questions,
We have almost numbering up to 99 questions now.
Yes.
Oh my God. We'll be here till 12 o'clock at night.
It's difficult for me to share.
Actually, something happened with Then there is a question asked by Prajay Lunia from Holy Spirit Hospital. Why is there a discrepancy between LPA and DST report? Can you take this up, Camilla? Till I get questions on WhatsApp?
Yeah, basically it's like this. One is when you do an LPA, you're doing it directly from the sample, right? So you need to see from where you've done the sample. If you get an LPA that is done direct smear positive, you do a LPA from there, and then subsequently you culture it and then do a DST. You are now doing a DST on what has grown best and what is grown. So if there's a mixture, you will grow on what is more fit and what is growing faster. So there will be a discrepancy. But if you go head to head, I mean, if you look at, say, LPA and expert directly from the sample, you shouldn't get a discrepancy. From midget and from LPA, you can get a discrepancy, and it's always best to look at what the discrepancy is about. You know, we actually sequence everything where we do get a discrepancy, and most often it's because the critical concentration may be too low. And when we do MICs, we find that the LPA or the mutation is possibly telling us the correct answer. Okay. But it's not often. It's barely 3 to 4%.
There is a question which has come. Is there any reason for phenotypic DST of pyrazinamide through midget is sensitive, while in Sanger sequencing it is resistance? Uma, can you answer this?
Much experience on Sanger sequencing, so I would not comment on that.
Okay. Anybody, Camilla or Jyoti?
See, ma'am, it's like this. The gold standard is pyrazinamide by midget today. Okay. Because it's well standardized. And the PNCA mutations are so many. There are at least 70 to 80 mutations that are defined by the PNCA gene. Today, if you do get a discrepancy, it's better to go to the WHO mutation catalog and see which mutations are definitely associated with resistance. And you'll find just about 20 or 30 are. So though the Sanger sequence may pick it up, you have to look at the catalog to decide whether that mutation is associated with resistance, whether it is associated with resistance intermediate, or whether it is an intermediate association. So these are really important points which the WHO mutation catalog offers you to check on.
Okay. I'm sure in the next upcoming webinars this would be answered. But there is a question, Dr. Jyoti, how to approach for non-tubercular mycobacterium diagnosis?
Yeah, so NTM, the initial detection would be that you would have a smear positive, but a CBNAT negative. So that would create a suspicion. And then we go for the conventional solid culture testing. We can go for the LPA, where we have, of course, most labs, like even we are in the government setup, we do not have the panels for testing for further testing for identification of the various NTMs. But conventionally, yes, we can go for solid culture. We have the whole battery of inoculating various culture media in light, in dark, then with the PNB, and various tests can be done to identify the NTMs. And of course, newer tests are there, and sequencing could be helping. I have not worked much on NTM, only in the initial years using the solid culture. Maybe ma'am has more experience with NTM, so ma'am can.
We are actually doing it when a clinician asks for NTM culture. We actually do an NTM PCR. Because sometimes even the smear may be negative, but clearly the first test is smear positive, expert negative. Then we do an NTM PCR. Subsequently, we put it on a battery of media, and once we grow it, then we identify it either on MALDI-TOF or we do the LPA. In fact, now an LPA DR has come, which is really a wonderful test because it tells you how you can pick up resistance to the ERM41, the RRL genes, etc. And we find that a very useful LPA, not the LPA1 to identify, but the LPA1 to do DR susceptible.
Yes, ma'am. Actually, even the midget system that way is very good for detecting NTM. Most of them grow on that. And basically, like Jyoti said, that the clue is that we see the AFP in the midget tube, and the card test for MPT64 is negative. That is a main clue. And of course, the other things like PCR and other things also can be done. And recently there is a genotype, that is LPA kit for direct samples also.
Yes.
It's called genotype direct. That also can be used directly from the sample instead of waiting for a culture and that one. That also can be done. Only thing, it's not routinely used under the programmatic settings, but wherever people would like to use it, that also can be used upon. And yeah, of course, the drug resistant, the NTM-DR is also a very useful thing for predicting the drug resistance to macrolides and so that is, but it gives for selected common NTM species, AVM, abscess, intracellular abscesses, and those kind of few selected isolates which are given in that. But definitely, it's a bone without instead of going blindly. That is a important tool as well.
Then there is another question which I found is very new to me also. What is clinical utility of cepheid 3-gene host response fingerstick blood test in TB? So I think this is a blood-based, PCR-based system. I'm not sure about it.
Yes, ma'am. It's a new test which relies on the host biomarkers to look at host prediction, how the patient is going to respond. These are host biomarkers where actually Zach and the South African group had identified 16 host biomarkers, and of the 16, the Cepheid has picked up 3. They are known as the Sweeney biomarkers, and to be honest, I don't think it's been that great in India for the few research studies that I've looked at.
Okay, so it should be a question for research. This was asked by Dr. Gyan Shankar. And then we have a question about now that we have newer guidelines for critical concentration to determine sensitivity or resistance. Please tell us about the critical concentration of drugs used for DST. And is there any standard concentration for all type of samples? Like, is there any difference whether it is a pulmonary sample or an extrapulmonary sample, and does the critical concentration specified varies? Can you answer that? Uma, do you have an answer to this?
No, we follow the WHO guidelines are there for each of the drugs. Sample-wise, there's no difference. We follow the critical concentration recommended. So recently also, they keep updating the thing, like previously, ma'am also told in our discussion, like for rifampicin, it was found to be higher. So they have recommended 1 gram, microgram. Now they are recommended for lowering it so that false positive is not detected. So we follow the guidelines.
Okay. Then there is another question, Jyoti. Please elaborate on phenotypic resistance and genotypic resistance. I'm sure each one of you have already explained in presentation. Jyoti, are you around?
Ma'am, Dr. Jyoti has left. I think she has some train to catch, I believe.
Okay.
So.
Okay. I think even I can answer that the molecular tests that you do are based on the chromosomal pattern and the genetic mutation that you observe or the presence of that. So these are genetic testing or genetic resistance genotypic resistance that you diagnose. And phenotypic resistance are that when these organisms we try to grow on the culture media, and then we do subcultures on the media which has those particular concentration of the drug, either MIC, which is described earlier, or the newer cutoffs that have been given. And these are the phenotypic diagnosis of resistance. Am I right?
Yeah, ma'am.
Yeah, yes.
Yes. With so many microbiologists around and so many questions coming up for laboratory and diagnosis, I thought maybe I should get some consideration. Then what is unstable hybrid term used for RIF resistant indeterminate? What is this? Even I'm hearing this for the first time. Unstable hybrid term.
Yeah, this is what happens when the load is very low in the sample, and rifampicin doesn't bind well. When it doesn't bind too well, it may stick on to certain areas of the RPO beta, and it's unstable because the load is so low, and that means that it's going to give a false resistance in vitro. So when the load is very low, please, and there's no risk factor for MDR, please would urge laboratories to give out the report as indeterminate, like Ultra has done. Ultra has eliminated the discussion completely. In trace and very low, it sometimes gives indeterminate. Indeterminate does not mean RIF resistance. In assays that we have done, we've analyzed about 930 samples of trace, and we found that almost 70% of them turn out to be midget. When they turn out to be midget positive, they are RIF susceptible. So don't think that RIF indeterminate means that it's possibly RIF resistance. It is not. More often than not, it means RIF susceptible.
Okay. So you have answered two questions. One was by Vinod Kumar and other by Pratibha, where she asked, what about indeterminate rifampicin resistance on Gene Expert? So I think both questions.
Yeah.
Yes.
Wait for culture. Yeah.
Yes. So you have already answered that. And so another question which has come up from Dr. Abhishek is, pediatric TB is usually possibacillary. Does pyrosequencing perform better than the canasta? I'm sure all are microbiologists around. Uma, do you have an answer to this?
Pyrosequencing, ma'am, does really well for CSF. We have patients who are expert negative, which grow on to culture and subsequently, and their pyrosequencing gives the result.
They matched with the pyrosequencing results.
Absolutely.
I remember I've seen that slide and publication also, I think I read in your presentation. Correct. Yes. So this is a wonderful question, though this is very basic. I think we need to answer it in affirmative. Dr. Nitin Kumbhare has asked, if NAT says M detected very low, do you take it as MTB detected and treat as TB? I think everybody would say in affirmation that once it is detected, it is detected. Though there may be, what do you say, not a consensus on the resistance pattern displayed, right?
Yes.
Another question is, which Camila has already answered from Pranavi, is in CSF analysis, is pyrosequencing preferred over Gene Expert? Yes, we do prefer that.
But it doesn't mean you shouldn't do. It doesn't mean you shouldn't do a Gene Expert. Do a Gene Expert,
yes.
And then if it's negative, then go ahead.
Yes. Another question,
the Gene Expert, ma'am, the Gene Expert here will be Gene Expert Ultra. I think here the program is now making arrangements that Ultra could be done for possibacillary samples, especially in children.
Yes. This question is from Dr. Ashwin Unni, and he has specifically directed it to Camila. But Uma, with your experience, even you can chip in. What is the present scenario regarding bedaquiline resistance in the laboratory? I presume that he wants to know about what is available in the laboratories.
We don't do the bedaquiline susceptibility currently. We refer it to the government institute.
Then this question is, even you can join in, Dr. Nayu and Dr. Chopra. What is the role of microscopy in the era of NAT? Is it going to become obsolete in near future? The smear microscopy.
The government recommendation is to use molecular test at in every sample at every place, but the infrastructure is not available. All molecular tests are not available. As I shown, % samples were tested on molecular tests. So the recommendation is to replace microscopy with a molecular test whenever they are available. So till molecular test is available as a point of care test at every place, microscopy still has got a role.
If I can say something. Yeah.
But we have to emphasize that whenever you're doing a follow-up of a particular case, then we have to do by smear and not by any of these genotypic techniques.
Molecular tests. So molecular tests are not used for follow-up. For follow-up, it will remain. Yes, ma'am.
Yes.
Besides the tubercular and MTB, you can also pick up the NTMs on the smear. So that's one way you can identify. If it's positive and gene expert negative, then you can look at the other option of
Look at for the NTM.
Yes. Another question is again for you, Dr. Jyoti. Dr. Uma. That is it okay to collect sample for NAT and liquid culture DST in autoclaved glass tubes instead of disposable falcon tubes?
That's a tough one. I would prefer a disposable, no chances of contamination, because sterilizing, repeating, and you have to re-verify whether that is actually sterilized properly unless you have the proper process, and then washing also without any acid or alkaline. All that needs to be checked. If you have an option for disposable, I would prefer a disposable.
Yes.
And moreover, glass tubes will have a risk of if they are accidentally dropped and those things can transmission can be there. So,
yes. Basically, I think, and you can all correct me because you are more experts and have been working in the laboratory, that falcon tubes are designed so that whenever you open the cap, the sample inside does not spill out with those movements. That is one. And secondly, you can put the falcon tubes directly for centrifuging and further processing. You can add the decontaminant or whatever other things you want to add to the sample and make it ready to be tested can be done directly into that falcon tubes. That is only the added advantage I think we have.
that is the reason actually we moved earlier. We used to have the wide mouth containers. From that we moved to the falcon tubes for this very same reason.
Yes. Anybody wants to add something because this is important?
Even the adequacy of sample also plays a very important role, ma'am.
Then there is one wonderful question from Karmai Shaha, which I think the presentations have explained, but we would just add a remark so that it is understood well. Under NTP, if the sputum or bile is smear negative, but expert positive, why LPA cannot be run directly on the same sample? Why do we want to do first look at the MZ growth and then we process for LPA? Is it a technological limitation or resource limitation in the program? You can answer that. No.
Technology limitation, because the limit of detection is just too low for LPA to pick up. It's nothing to do with resources. The program is bending its back over to spend resources on this, but LPA is just the limit of detection is not up to speed for LPA. They're now trying to look at it for possibacilli, but as of now, it's still not applicable.
Yes. So that we had, and if first line LPA gene loci is absent for INHA, but CAT-G is okay, in this case, can we release the results or put samples, or do we need to put sample on liquid culture? I think for this, even I can answer. I don't know whether I'm right or wrong. You should release the reports and let the clinician decide about the further treatment. However, we have to put the sample for liquid culture as is already a built-in cascade in the program and in the laboratories, and then you look for resistance for other drugs also. Am I right?
Actually, ma'am, I would rather repeat it. I'm very particular about the loci. So the loci that shows that the test has been done well. I would repeat it, and if it came again, then I would go for liquid culture and leave it to the clinician to decide till the culture comes first.
Then a question from Dr. Ipsita is, can urine be run on Gene Expert?
So there's no recommendation
as of now, no.
But there are many laboratories and studies being done where they have got good results, but they don't recommend it. WHO
Lamb is
doesn't.
possibly better. The newer generation lambs are better.
Yeah.
Yeah, but clinicians often do come up with a request of CVNAT for urine sample. We have done in a few cases, but we always do it in combination with culture. And our experience has been is many cases actually it's picked up often by the culture rather than by the gene expert. That's a limitation. It can be quite often false negative. So that's why we don't routinely recommend gene expert or a TrueNat for a urine sample. Better would be to do the culture with more volumes. We usually go for multiple, for 3 or 4 containers of 40 ml each, centrifuge it, and then we used to do it. That way our yield of MTB from urine sample has been good for midget culture as well.
Yes. So actually, wherever the samples are huge, I think the guidelines are there, or we need to have like how, in which way do we process? Like even for pleural fluid, ascitic fluid, the samples are huge, and if that particular representative sample does not have the bacilli, we would be missing on the diagnosis. So we need to first process and follow the guidelines for how such large voluminous sample needs to be processed. And then you perform the test. So do we have such guidelines?
No, ideally, it's to send the whole sample to the laboratory. I think that's one thing which has to be done.
Yes, we have, ma'am, for urine, we take the entire morning sample, even if it is 300, 400, 500 ml. The morning sample is best because it collects the bacilli over the night, and the entire morning sample is taken over 3 days, and we spin it, and midgets are done, and we have really good results with urine midgets when we do this. If you compromise on the quantity, you will because they are all paucibacillary, so we give big jars to the patient, say everything you give in the jar and give it to us.
So there is one question which I'm sure even Dr. Chopra has it in his mind. How do you deal with this? Like usually what we observe is that if such a huge sample is taken to a window, the technician would take 10 ml from it and throw away the remaining. So how do you ensure that such samples are, kept waiting or are processed in the way you want it to be? All three of you must answer this.
Routinely, we always advise, as Dr. Kamila said, we always advise patient to collect 24-hour urine sample in glucose bottles and bring it to the laboratory. This is the routine instructions we give. But whatever, I don't know what the laboratory technician does, whether they collect all or centrifuges and then put on.
We have 10 centrifuge tubes for each urine. So we are centrifuging every bit of it, taking the sediment and then.
Okay.
So you need to really struggle. Our technicians hate urine samples because they have got to, mess with so many falcon tubes.
We have to insist with the technicians to do that. Otherwise, we keep on checking in between. And one more thing, sir, you was mentioning about the 4-hour sample storage. Actually, if the patient is collecting the urine for a prolonged period, they should be kindly advised to keep it in refrigerated temperature, 2 to 8. If it is kept for a long period outside, the normal flora again can overgrow, and despite contamination might be a problem. Despite decontamination, that might be a problem. So I would suggest that prefer would be the early morning sample. Even if we get a good catch of the early morning, that would be the better rather than overnight, because most patients will not comply with that. Even if we say that they won't prefer keeping the urine sample in the fridge. So best would be, like Camilla madam said, that early morning sample. We'll get a good volume, and that will be better samples.
We have a question here which says that if NAT says MTB detected very low, RIF resistance detected, but if there is no history of TB in the past, we repeat the sample and test for rifampicin resistance again. So the question is, can we start patient on DST TB regime till we get a repeat test report, or should we wait for the report?
See, it's like this, ma'am. I think culture is more reliable in this setting. If you're not, it all depends on clinical history. If he's got risk factors for MDR, then believe the riff resistance. If he's a virgin case and first time, I think we wait for culture.
We wait for cultures. That is it. This is also a good question. Do you interpret trace report in Ultra Gene Expert differently if the sample is sputum and if the sample is BAL, that is from directly lungs, or a targeted sample? This is specially for Camila. This has come from Ajay Godse.
See what we do now. We've had so many bad experiences with Gene Expert reporting trace, and the patient may have a malignancy. So when we get a Gene Expert and the clinician is suspecting a malignancy, see, there is a working diagnosis when you do a BAL, right? You know what you're dealing with. So in that case, you wait for histopathology. You keep the sample in the fridge. And if histopathology shows a malignancy or shows something else, you do not do, and you're not suspecting TB. I think here it puts the clinician on the spot, because you have to have a working diagnosis of TB to interpret that trace result. If it's just being done, chalo bhejo, sab kuch bhejo, ye karo, wo karo, then there's no pre-test prevalence. Pre-test prevalence is the most important factor in interpreting any test. You will get false positives if you're just sending off all the tests just because they're free or just because they're available. The clinical aspects must be considered. There must be a pre-test prevalence of considering TB when you ask for an ultra. And we find that when you sort of triage these samples like this, you get better results, and you're not struggling with ultra trace results.
Okay. This question has come specifically for Dr. Uma. We have done TB culture liquid and solid. The midget has no growth after 6 weeks, whereby the LJ has one single colony, and when performed it from the colony MTB detected, why the MJIT has no growth, whereas LG is showing a growth? Why does this happen?
Well, probably it could be again in the concentration, the processing could be one of the reasons.
Okay. Camila, do you have any opinion? You have some other opinion on this?
No. What was the question, ma'am? LJ grows and midget doesn't grow?
Midget doesn't grow,
that
and
is because,
LJ has.
Yeah, that is because there's about 1.5% of TB bacilli are egg dependent. They need egg to grow. So that is why traditionally you're supposed to use a midget and you're supposed to use an LJ, so that you can have that some TB bacilli really like eggs. So they grow in the presence of eggs and they don't grow in midget. It's known.
Normally,
so it's
when
better
we process, when we process a midget, we always put a backup LJ.
Correct.
Also.
Absolutely.
If Camila, if MTB could hear, they would say a dialogue from Andy, कोई खूब जानता है मेरी पसंद को, पसंद ना पसंद को. Wonderful. Then there is a question from one question is, please comment on CBNAT on stool samples in suspected cases of abdominal TB. Why I took this question is that we know that stool samples can be processed in children whenever we suspect PTB for obvious reasons. But this question is specifically for abdominal TB. Any of you who can answer this? Noel?
No, ma'am. We have been doing it for pulmonary TB, like you said.
Yes.
But we don't have direct experience on doing it for abdominal TB, gastrointestinal TB that way. Because I'm really doubtful how much would be the load and the stool sample in that cases.
Actually, the basis of testing stool for MTB is that the children are not producing the sputum sample and swallowing it, and from there it goes to the stool. Whereas in abdominal TB, whether there is really shedding of bacilli into the gut is a question which I myself do not know the answer to. If any
don't
of our
think it applies,
panelists have the answer,
No.
yes?
I don't think it applies. I'll tell you
Yes.
why. Because there are lots of peritoneal nodules in abdominal TB that you pick up when you do a laparoscopy. The biopsy is taken. Some are outside the gut. It's very, very difficult to do it. And even at the ileocecal region, it's so full of bacteria that it's not something that we would want to do.
Yes, and I believe that most of these bacilli are inside the lymphocytes, where the those granulomas are inside the intestine, and they are not superficial. Basically, they are inside. That is why even superficial biopsies may not give you a good sample. If you take only the mucosa, you may not get a sample. A proper report. So as of now, the answer is as of now, we do not have any evidence as well as first-hand experience of diagnosing abdominal TB by doing the test on stool sample, NAT on stool sample. And we await perhaps few of the panelists as well as the audience who have logged in would take this up as one of the research questions and come up with an answer. And that's an appeal also, not a hope, but also an appeal. What is the role of TB LAM in healthy adult and an immunosuppressed patient?
TB LAM has been well defined, ma'am, for HIV patients where the viral load is high and the CD4 counts are really low. The newer TB LAM, that is the second and third generation TB LAMs, which are yet to come out for us in India, will be better placed for looking at healthier patients who have for them. As of now,
we should say not healthy, but non-immunocompromised.
Yeah, non-immune. Sorry, the non-immunocompromised.
No, that was in the question itself. It was healthy.
No.
It's not your mistake.
Yeah, but the second and third generation may be better placed. As of now, with the LR test, no, in non-HIV patients, it has a role.
Yes. Wonderful. So that answers so many queries in the minds of audience about LAM, right? And there have been many questions for CBNAT from stool samples and all. There is, there are a lot of questions being asked about even treatment, which I'm not taking up because our webinar primarily focuses on diagnostics. And I appeal to my audience that please forgive me if I have not taken up their questions, though they are very interesting, they are very relevant, but we have to finish with the questions related with diagnostics first. What is the role of locus control in LPA? Because I myself do not know what it is. Locus control in LPA. Can anybody answer?
Noel, go ahead.
Yeah. That basically looks for that presence of that particular. We are looking for that locus for each of the gene target, both the wild and the mutant. It looks for that, whether that area is being screened in that. Because if that is missed and the interpretation of the LPA might be this one invalid. So that is what first we need to look for that before going for interpretation of presence of wild or the absence of absence of wild or the presence of a mutant.
There are few questions which are asking about the sensitivity and specificity about TrueNAT, but they have asked in relation with LPA. So if somebody can take up that there was a case of pleural effusion which came negative by TrueNAT, but turned out to be RIF resistance on LPA. I think this has...
Was it
I
smear
think this
positive?
has mainly to do with the way in which the samples were processed and taken, right?
Yeah, first, we need to know whether the smear, it was directly smear
Yeah,
positive
smear
or not. That
positive
is
or
not
not.
mentioned in the first stage.
Yes, but if the direct smear is positive, it cannot come negative by TrueNAT.
Correct.
Yes, and like,
So
So
probably the
Madam,
LPA was, yes?
from the culture. The LPA may have been
Yes,
done
from the
from the
culture.
cultures,
You
and
done
it,
from the culture.
as we know that cultures would always be giving, more reliable reports or results.
Yes.
Madam, will you excuse me? I have to leave now.
Actually, I think we need to even wind up. We have crossed our time.
Yes, yes.
And I again apologize to the audience whose questions could not be answered. We have a huge number of, I think we have answered only 1/3 of them. And my panelists have been wonderful, each one of them, including Dr. K.K. Chopra. Sir, there were very few questions directed to you, and few were based on treatment, which I did not take. So my apologies that I directed very few questions to
problem.
you. And Uma and Noyal and Jyoti and Camila had maximum questions, and many are pending. But we cannot take up. My apologies for making it so late and keeping everybody waiting there. But then the webinar, which has wonderful panelists and a huge number of questions, cannot be stopped abruptly. I think this is all from my side. And team from BD, would you like to take up before we end? And everybody, do you want to add one sentence before we end?
Yeah, I think let the panelists have a word first, then we will
Yes.
close the session.
The last line, yes.
I would like to say a very, very basic thing. The sample collection, especially sputum, where you're collecting and how you're collecting. It cannot be done in the same place where a phlebotomist is collecting. You should need to identify a separate place because it's a chance where it could spread to the other people. So I think that is something very basic we tend to ignore. Thank you.
Noyal?
My
Yeah,
point would be to insist on sending two samples when we send for CBNAT or TrueNAT, because only then we can do the other testing. Because quite often, especially in a government setting, what we face is the patient comes and gives the first sample and goes. We detect it, and then further we are, in case it is rifampicin resistant, we are not able to do the further testing. Or if it is even if it is rifampicin sensitive, we have to work up for INX, but that possibility is not there unless the clinicians routinely provide two samples. So that has to be really emphasized.
Yes. Thank you. Camila, would you like to add?
I think we've come such a long way. TB diagnostics are a dream from what they were 10 years ago. But we need to continue to work towards universal access to DST that is equitable and affordable. And I think India is doing in a fine place. And we need to go forward like that. Thank you.
Yes. Dr. Chopra?
Yeah, I'll repeat that Dr. Kamila's comment that clinical history and clinical interpretation should be with the diagnostic. In many difficult cases, as ma'am said, if we know the clinical suspicion, it is better to interpret the results in difficult cases.
Well said. And before we hand over to BD, let me tell everybody, the audience, that there are so many newer tests which has come up with different people working on it, including BD. And I'm sure ICMR is flooded with so many tests for validation. And once they are validated and given a green signal, we would have many more handy tests which would be cost effective, affordable in our country, and would also offer point of care diagnosis, not only for the disease of TB, but also will tell us about the resistance to at least basic drugs like INH and rifampicin. Over to you, Kaushik.
Thank you, ma'am. I think it was a wonderful webinar, and thank you, audience, first of all, for joining in large numbers. We had more than around 650-700 participants joining in live, and more than around 1,500 registrations for the webinar. A big thank you to all. Then a huge thank you to the different associations which came up, the ICS, the Union, and others. So thank you very much. And to the moderator, Dr. Radha ma'am, it was very well moderated. And thank you for staying up for such a long time and then moderating the session, especially the question and answer and the panel discussion part. Thank you, speakers, Dr. Uma ma'am, Dr. Noel sir, Camilla ma'am, and KK Chopra sir, and Jyoti ma'am also, though ma'am is not now here. So it was really wonderful, very good talks, and thank you for staying back and answering all the questions. We have many more questions just still unanswered, so I think we'll be sending across the questions across to all the panelists, and hope to get answers so that we can send it back to the audience, so that none of the questions go
Yes.
unanswered.
In fact, you can come up with FAQs, frequently asked questions and their answers.
Yes. I think many very relevant questions have been asked by the audience, and very
Yes.
interesting questions just come up. So I think
Yes.
thanks audience for giving all your questions. So I think more than what we had thought of, we have got so many questions which has come in. So there's not a single webinar. We have 2 more webinars to go. So hopefully we'll get
Yes.
more number of audiences, more number of insights into TB diagnostics, and how we are able to treat, diagnose, and then treat the patient. So I think it was a wonderful webinar, and thanks to my BD team also for supporting us, and hope to see you in the next webinar. Thank you all.
Yes, and thanks BD for this first ever in your series of diagnosis of TB. I, on behalf of Indian Chest Society, thank BD as well as the other partners, the union and the Central TB Division for this a novel venture, which marks a day prior to the eve of World TB Day. And we hope that with not only participation in this, but actively doing it for our own patients, a good job of early diagnosis and a proper treatment would definitely take us away towards our goal of ending TB. Thank you, everybody. Thank you.
Thank you. I think one more point before we end. I think this is a recorded session, so we will be putting it across on our video on demand platform. So all those who have not been able to join in or who want to look at it again, it will be still possible for you to look at the full video on our video on demand platform. We'll be sending across the links to you very shortly. Thank you.
Thank you.
Thank you all. So we'll be ending the webinar now. Thank you.
Thank you.
Thank you.
Are we off air?
Yes, ma'am. We are off air now. Thank you.